Every clinician faces this moment. A patient recounts a sudden dramatic pop at the back of their heel, often described as feeling kicked or even shot. This isn't just a painful incident, it's the signature of an Achilles tendon rupture, an injury that, despite its, well, classic presentation, is alarmingly missed in up to a quarter of patients. And its incidence, remarkably, seems to be on the rise, challenging our historical perceptions of who gets these ruptures, how, and why. Welcome to the Deep Dive, your direct route to becoming truly well informed on complex medical topics. Today, we're unraveling the intricacies of Achilles tendon ruptures, an injury that demands not just diagnostic precision, but actually a nuanced, evolving approach to management. This deep dive is crafted specifically for you, our mid to senior medical professionals, to equip you with the latest evidence based insights and maybe provoke some critical thinking on the very controversies shaping orthopedic practice right now. To navigate this dynamic landscape, we're truly fortunate to be joined by Professor Mo Imam, whose profound expertise and clinical wisdom in orthopedic challenges are invaluable. Professor, we're delighted to have you share your insights. Our mission today is clear: to provide you with a comprehensive, cutting edge understanding of Achilles tendon rupture, from its subtle anatomical vulnerabilities right through to the latest rehabilitation protocols, pushing you to critically evaluate how we approach these challenging cases. So let's unpack this from the ground up. The Achilles tendon is universally described as the body's largest and strongest tendon. Could you perhaps set the scene for us, detailing its crucial anatomical role and how it so powerfully facilitates human movement?
It's an absolute pleasure to be here. And you're right, it really is a marvel of biomechanical engineering. The Achilles tendon, typically stretching about 15 centimeters, isn't just one tendon. It's actually a formidable convergence of the three major calf muscles, the soleus and the medial and lateral gastrocnemius. These muscular bellies seamlessly transition into this incredibly robust tendinous structure, which then powerfully inserts into the posterior aspect of the calcaneus, or the heel bone, as you know. Its primary, indeed indispensable function is plantar flexion of the foot, that downward movement of the ankle. This is absolutely critical for virtually every propulsive movement we make, from simply pushing off the ground when walking to generating explosive power for running, jumping, and even climbing stairs. Without a fully functional Achilles, well, these activities become severely impaired, impacting mobility and quality of life profoundly. What's also fascinating about its anatomy, and highly relevant to its susceptibility to injury, is its unique spiraling configuration. As it descends from the calf muscles towards the heel, it undergoes an approximately 90-degree lateral twist before its insertion. This intricate twisting pattern isn't merely aesthetic. It's thought to distribute forces more evenly across its fibers and perhaps enhance its energy storing capacity, allowing it to act like a highly efficient spring, absorbing and releasing energy during dynamic activities. This characteristic, known as its viscoelastic property, enables it to deform under stress and then return to its original shape, which is fundamental to its role in locomotion. However, despite this inherent strength and design, there's a notorious vulnerability: the hypovascular region. This zone, typically located about 4 to 6 centimeters proximal to the calcaneal insertion, is notoriously poorly supplied with blood. Studies have shown significantly reduced capillary oxygenation and microperfusion at this 5-centimeter mark compared to areas closer to the muscle or bone. This diminished blood supply is a primary reason why this specific region is so prone to rupture. Its main blood supply originates from the posterior tibial artery, while its nerve supply primarily comes from the sural nerve, with a smaller contribution from the tibial nerve. Understanding this anatomical weak spot is key to understanding why ruptures occur where they do.
That structural detail, particularly the twisting and that specific hypovascular region, really underscores its paradoxical vulnerability despite its strength. So while it's a powerhouse, it's also remarkably susceptible to injury. What are we seeing in terms of the actual prevalence of these ruptures now, and crucially, who is most commonly affected? Has the typical patient profile shifted over time?
Its vulnerability is indeed a growing concern. The prevalence of Achilles tendon ruptures has been on a significant upward trend globally. Recent studies report incidence rates as high as 40 per 100,000 people annually. This isn't just a static figure, the trajectory is quite striking. For instance, in Sweden, data from their National Patient Register revealed a substantial 45% increase in Achilles tendon rupture cases between 2002 and 2021.
Similar patterns have been observed in other Nordic countries like Finland and Denmark, indicating a widespread increase, although it's interesting to note that some recent data from East Asia has shown a plateau or even a slight decrease in incidence after 2009.
A 45% increase, that's significant.
It really is.
Yeah.
And when we look at the demographics, Achilles ruptures are still predominantly seen in men, with a male-to-female ratio that hovers around 4.8 to 1. Historically, the most commonly affected age group was typically between 30 and 40 years old. However, this is where the picture has notably changed, and this is a critical insight for clinicians. We're now observing a distinct and impactful shift in the median age of patients, which has moved closer to 50 years. The highest increase in incidence is now concentrated in the 40 to 80 age group, particularly among those born in the mid-20th century who are now in their prime, older adult years.
So not just the young athlete anymore.
Exactly. This demographic shift fundamentally challenges our historical perception of the Achilles rupture as solely a young athlete's injury, demanding that we now recognize it as a significant concern for an increasingly active, older population. This, of course, brings its own set of management complexities, given potential comorbidities in this older cohort. A significant contributing factor, especially within recreational sports, is what we term the weekend warrior phenomenon. These are individuals who may not maintain consistent physical conditioning throughout the week, but then engage in sporadic, intense bursts of physical activity on weekends. This pattern of inconsistent, high-load activity significantly contributes to their risk of injury, with approximately 75% of these ruptures occurring during recreational sports.
That demographic shift is truly striking. It really forces us to reevaluate our patient profiles. So, beyond that age shift, what are the specific underlying factors, both intrinsic to the patient's biology and extrinsic from their activities or environment, that are conspiring to contribute to these ruptures? What's the deeper pathophysiology at play here?
It truly is a multifactorial problem, a confluence of vulnerabilities, really. Let's delve into the intrinsic factors first, those inherent to the individual. Age and degeneration are paramount. As people age, the Achilles tendon undergoes structural changes. It naturally loses its elasticity and strength, becoming stiffer and less tolerant of load. This is primarily due to changes in collagen organization and content. A healthy tendon is predominantly composed of robust type I collagen. However, with age, and certainly after injury, we see an increase in less organized, weaker type 3 collagen. This structural disarray makes the tendon significantly more susceptible to rupture.
So the quality of the tissue itself changes.
Precisely. And beyond age, various chronic systemic conditions play a significant predisposing role. We frequently see associations with chronic renal failure, and within this population, there's an increased risk, often compounded by the necessity of medications like fluoroquinolone antibiotics and corticosteroids, which are themselves known to weaken tendons. Metabolic abnormalities, such as hyperparathyroidism, common in end-stage renal disease, further contribute to this vulnerability. Other significant systemic conditions include collagen deficiencies, which impact the tendon's fundamental building blocks, diabetes mellitus, which leads to increased tendon stiffness, thickening, and disorganized collagen fibers, impairing its ability to dissipate stress, gout, certain infections, autoimmune conditions like lupus and rheumatoid arthritis, and various thyroid disorders. All these conditions can subtly or overtly compromise tendon integrity, making it less resilient to normal forces.
And local factors, foot shape, mechanics.
Yes. Locally, certain foot problems and biomechanical imbalances can also predispose individuals. Conditions such as cavus foot, where a high arch can alter load distribution and increase strain on the posterior chain, insufficient gastrocsoleus flexibility leading to tight calf muscles, limited ankle dorsiflexion, tibia vara, and a varus alignment with functional hyperpronation, where the foot excessively pronates during weight bearing, can all create abnormal stresses on the Achilles tendon, increasing its risk of injury. Overuse and repetitive stress are also major intrinsic contributors. Activities involving chronic repetitive microtrauma, particularly high-impact sports like running and jumping, can weaken the tendon over time through cumulative damage. The concept of load spikes, where there's a sudden, significant, and unaccustomed increase in activity intensity or volume, is particularly relevant here. The tendon simply isn't given enough time to adapt to these new demands.
Right, the tissue isn't prepared.
Exactly. And finally, muscle tightness, specifically insufficient flexibility in the calf muscles, can dramatically increase the strain on the Achilles tendon, making it more prone to rupture during sudden movements.
Okay, so those are the intrinsic factors. What about the extrinsic ones? The activities, the environment?
Now, shifting to extrinsic factors, those originating from the environment or activity, sudden intense physical activity is a primary culprit.
Sports like soccer, basketball, and racket sports, which involve rapid accelerations, decelerations, and sudden changes in direction, are frequently implicated. Around 78% of Achilles ruptures occur during these types of athletic activities. Inadequate preparation is another key factor. Insufficient warm-up, or an abrupt increase in activity intensity without allowing the tendon to gradually adapt significantly heightens risk. Think of that weekend warrior scenario again.
Makes sense.
Poor footwear, particularly unsupportive or worn-out shoes that don't provide adequate cushioning or stability, can also alter biomechanics and increase strain on the tendon. Lastly, certain medications are well-recognized extrinsic risk factors. Fluoroquinolone antibiotics, prolonged use of corticosteroids, both oral and injected, and oral bisphosphonates have all been implicated in weakening the tendon's structural integrity, making it more susceptible to rupture, often with minimal inciting trauma. It's truly a complex interplay of these intrinsic vulnerabilities and extrinsic stresses that culminates in an Achilles tendon rupture.
That's a truly comprehensive, almost layered picture of the underlying mechanics and predispositions. It makes you realize just how many factors can be at play. Now, when a patient walks into your clinic, often with that dramatic story of a pop or snap, what are the key symptoms and historical markers that should immediately raise a strong suspicion of an Achilles tendon rupture for an experienced clinician? What are the immediate red flags you're looking for?
The clinical presentation of an acute Achilles tendon rupture is indeed often quite classic and, as you say, dramatic. Patients almost invariably report a sudden, distinct pop or snap sensation at the back of the leg. They often vividly describe it as feeling as though they've been kicked or shot in the calf. This is almost immediately followed by acute, sharp pain in the heel or calf region. They'll then experience immediate and profound weakness, specifically difficulty walking normally or standing on their tiptoes. On examination, you may also observe visible swelling and bruising in the affected area, particularly within the mid-calf down towards the heel. In cases where the injury might have been missed or is more chronic, you might even note some subtle calf atrophy in the affected limb compared to the uninjured side, or an increased resting ankle dorsiflexion when the patient is lying prone with knees bent. The inability to effectively push off the ground with the injured foot is a consistent complaint.
And the physical exam itself, beyond the history.
Beyond the history, the physical examination is absolutely paramount for a confident diagnosis. The Thompson test, also known as Simmons test, remains the pivotal clinical diagnostic tool. It boasts exceptionally high sensitivity, ranging from 96% to 100%, and an impressive specificity between 93% and 100%. To perform it, you position the patient prone with their knee flexed to about 90 degrees, allowing the foot and ankle to hang freely. You then firmly squeeze the calf muscle. The critical observation is the presence or absence of passive plantar flexion at the foot and ankle. A positive test, indicating a rupture, is the absence of this expected plantar flexion.
So no foot movement means a likely rupture.
Exactly. Other crucial examination findings include the presence of a palpable gap or discontinuity in the tendon, typically found in that hypovascular region 4 to 6 centimeters above the calcaneal insertion. While swelling can sometimes obscure this in acute presentations, a skilled hand can often detect it. You'll also note significant weakness to ankle plantar flexion against any resistance, and often an increased passive dorsiflexion range compared to the uninjured side due to the loss of the tendon's natural tension. Some clinicians also use Simmons triad, which is a confirmatory set of signs: a positive calf squeeze, Thompson test, an altered angle of declination, the foot hanging more dorsiflexed, and a palpable gap in the tendon. These three signs together strongly indicate a complete rupture.
Given that remarkably high sensitivity and specificity of clinical tests, like the Thompson test, it's genuinely astonishing to hear that over 20% of Achilles tendon ruptures are reportedly misdiagnosed. That's a significant figure. What, in your experience, are the common pitfalls that lead to these misdiagnoses, and what key differential diagnoses must clinicians rigorously consider when evaluating a suspected Achilles rupture?
That misdiagnosis rate is indeed a profound concern, and it highlights a critical point. While the Thompson test is powerful, diagnosis is about the entire clinical picture. The pitfalls often stem from incomplete examinations, perhaps relying solely on one symptom or failing to appreciate the nuances. For instance, a partial rupture might still elicit a weak plantar flexion response, leading to a false negative. Significant swelling can obscure a palpable gap, and in some cases, patients may present with less dramatic pain, leading to a downplay of the injury's severity.
So it requires thoroughness.
Absolutely. To avoid these errors, clinicians must systematically consider a range of differential diagnoses. Firstly, Achilles tendonitis or tendinopathy is a very common mimicker. While it causes pain in the same region, its onset is typically more gradual, there's no culpable gap, and crucially, the Thompson test will be negative. The pain is usually activity-related and gradually worsens.
Okay, tendinitis. What
Yeah.
else?
Ankle sprains, particularly severe lateral ankle sprains, can also present with pain and swelling around the ankle. However, the mechanism of injury, say an inversion injury, and specific ligamentous stress testing should help differentiate these. Calf muscle injuries, such as a gastrocnemius or soleus muscle strain or rupture, are another key differential. These can cause acute pain in the calf, often described as a tennis leg. However, muscle ruptures typically occur higher in the muscle belly, and critically, the Thompson test would generally be negative or show some residual plantar flexion because the Achilles tendon itself is intact. The pain is more diffuse in the calf, often with the visible hematoma higher up.
Higher up, right.
Calcaneal fractures, particularly avulsion fractures of the heel bone where a piece of bone is pulled off by the tendon, are important to rule out, especially in cases of significant trauma. This is a primary reason why radiographs are often obtained. Then there's deep vein thrombosis, DVT, which absolutely must be considered. It presents with calf pain, swelling, and tenderness, making it a critical, potentially life-threatening consideration due to its serious embolic implications. Other conditions include Achilles bursitis, ankle impingement, ankle osteoarthritis, exertional compartment syndrome, fascial tears, Haglund deformity, plantaris tendon tear, even systemic conditions like psoriatic arthritis or Reiter syndrome.
A long list.
It is. Less common but still relevant are retrocalcaneal bursitis, a ruptured Baker's cyst, and injuries to the tibiofibular syndesmosis or talofibular ligaments. The key, as you highlighted, is a meticulous systematic approach to history, physical examination, and then judicious, targeted use of imaging to confidently distinguish between these conditions.
That's an exhaustive but vital list, Professor, and it truly drives home the need for that meticulous diagnostic approach. Speaking of imaging, while those clinical tests are clearly primary, what are the specific roles of radiographs, ultrasound, and MRI in the diagnostic pathway for Achilles tendon rupture? How do they complement or clarify the clinical picture?
Absolutely. While clinical examination, particularly a well-performed Thompson test, is often sufficient for diagnosing acute Achilles tendon ruptures, imaging plays a crucial complementary role, especially in certain scenarios or for preoperative planning. First, radiographs or X-rays. It's important to understand their primary utility here. They are not used to directly diagnose the soft tissue injury of the Achilles tendon itself. Their main purpose is to rule out other bony pathologies that might present with similar symptoms or complicate management. This includes excluding calcaneal fractures, which could be avulsion fractures where a piece of the heel bone has been pulled off by the tendon, or other fractures around the ankle.
So X-rays for the bones, essentially.
Exactly. So if a patient comes in with significant pain and swelling following trauma, an X-ray can quickly give you a clear picture of the bone integrity. Next, ultrasound. This is an incredibly useful modality and is often considered the first-line imaging choice once a rupture is clinically suspected. Its advantages are numerous. It's cost-effective, readily available in most clinical settings, and crucially, it's radiation-free. This makes it an excellent dynamic bedside tool.
Quick and easy.
Precisely. Its utility lies in its ability to quickly and accurately determine several key characteristics of the rupture. It can tell you whether the rupture is complete or partial, its precise location, mid-substance, myotendinous junction, insertion, and critically, the size of the gap between the torn tendon ends. This information, particularly the gap size and the degree of retraction, can significantly influence the management decision, informing whether non-operative or operative treatment is more appropriate. Ultrasound also allows for dynamic assessment, observing tendon movement with ankle flexion and extension. It's a quick, efficient way to confirm and characterize the injury.
An MRI, when does that come in?
Finally, we have MRI, or magnetic resonance imaging. While MRI offers the most highly detailed soft tissue imaging, its indications for Achilles tendon rupture are more specific. It's typically reserved for cases where the physical exam findings are equivocal, meaning the clinical picture isn't clear-cut or there's diagnostic uncertainty. It's also invaluable for chronic ruptures, where the diagnosis might have been delayed or the local anatomy has become distorted by scar tissue or tendon retraction. MRI is also extensively used for detailed preoperative planning. It can precisely delineate the exact extent of the rupture, differentiate subtle incomplete ruptures from pre-existing degenerative changes like tendinosis or peritonitis, and assess for any associated conditions within the tendon or surrounding tissues.
But it has downsides.
It does. MRI can be more time-consuming to schedule and perform. It's significantly more expensive than ultrasound, and any delays in obtaining an MRI can potentially delay surgical treatment, which can be time-sensitive in acute cases for optimal outcomes. Despite its detail, it's worth noting that clinical diagnostic criteria for acute ruptures are often more sensitive than MRI studies in the very acute phase. So it's not always the first or best choice initially.
Thank you for clarifying the nuanced roles of each imaging modality. It's clear that it's a careful hierarchy based on the clinical question at hand. Now let's move into the realm of treatment, which has seen a considerable evolution. For decades, open surgical repair was often considered the gold standard, but the landscape of Achilles tendon rupture management has notably shifted. Could you explain the historical context and, critically, the current evolving consensus on treatment approaches?
This truly is a fascinating area, demonstrating how evidence can shift long-held clinical practices. Historically, as you correctly pointed out, open surgical repair was indeed widely considered the gold standard for acute Achilles ruptures. This preference was largely driven by a very legitimate concern over what were perceived as unacceptably high re-rupture rates with conservative, non-operative treatment, often reported anywhere between 10% and a staggering 40%. The prevailing consensus was that surgery offered a significantly lower re-rupture risk, typically in the range of 1% to 2%, making it seem like the clear choice to protect the patient from re-injury.
That's a huge difference in re-rupture rates.
Historically, yes. However, over the past 15 years, we've witnessed a significant paradigm shift. What's remarkable is that despite an overall increase in the incidence of Achilles ruptures, the incidence of surgical intervention has actually seen a proportional decrease in some regions. This shift towards increased non-operative management has occurred concurrently with the publication of multiple, high-quality, well-designed randomized controlled trials. These trials have rigorously compared operative and non-operative treatments for acute Achilles ruptures and, crucially, have demonstrated comparable outcomes, particularly when advanced, accelerated functional rehabilitation protocols are consistently employed for both groups. So the rehab made the difference. It appears to be a major factor, yes. So what's the current consensus? It's no longer a simplistic surgery-for-all approach. The decision for treatment has become highly individualized and nuanced. It requires a careful weighing of multiple factors in collaboration with the patient. These factors include the patient's age, their activity level and specific demands, the presence of any medical comorbidities that might increase surgical risks, the chronicity of the injury, and critically, the patient's preferences regarding the risks and benefits of each approach.
So it's a shared decision.
Absolutely. For instance, a highly active patient or professional athlete aiming for a quicker return might accept a slightly higher surgical complication rate to minimize re-rupture risk and potentially accelerate return to peak performance. Conversely, a less active patient or one with significant medical comorbidities might prefer a non-operative route to avoid the risks associated with surgery, like infection or wound complications. The understanding now is that inappropriate treatment, whether surgical or non-surgical, can lead to considerable functional impairment, so the decision requires a thorough shared discussion and an appreciation of the latest evidence.
That's a truly crucial point about individualized care and shared decision-making. Let's delve deeper into non-operative management then. Who is it typically recommended for in this modern context, and what are its core components, and most importantly, its outcomes in the current era of advanced rehabilitation?
Non-operative management has indeed transformed. It's typically recommended for several patient profiles. Primarily, medically frail or sedentary patients for whom the risks of surgery outweigh the potential benefits. It's also suitable for those with significant medical comorbidities, such as severe diabetes or vascular disease that might contraindicate surgery or significantly increase surgical risks. And of course, for patients who simply express a strong, informed preference for avoiding an operation, especially when outcomes are now proving comparable. The integrity of the overlying soft tissues or skin around the tendon is also a factor. Compromised skin might favor non-operative care.
And what does it involve?
The core components of initial non-operative care are well established. It begins with immediate rest for the injured limb, elevation to control swelling, and appropriate pain management, often with NSAIDs in the acute phase, though their long-term impact on healing is debated. Crucially, this is followed by immediate immobilization. This can involve an initial back slab plaster cast, transitioning rapidly to a functional brace or casting. The limb is immobilized in the position of resting equinus, typically around 20 degrees of plantar flexion, reducing tension on the healing tendon ends. As healing progresses, the angle of plantar flexion is gradually reduced over several weeks, slowly bringing the foot towards neutral.
And the outcomes, you mentioned they're comparable now.
In terms of outcomes, This is where the significant shift in evidence base has occurred. Recent studies, particularly when functional rehabilitation is meticulously employed, show equivalent plantar flexion strength compared to operative management. What's even more compelling, and a genuine game-changer, is the emergence of new Level 1 evidence, suggesting that there's no statistically significant difference in re-rupture rates when functional rehabilitation protocols are rigorously used with either non-operative or operative approaches.
No difference in re-rupture. That's huge.
It is. While historically non-operative management was associated with re-rupture rates as high as 10% to 40% compared to 1% to 2% for operative repair, this gap has dramatically narrowed or even disappeared with modern, well-structured functional rehabilitation. The primary advantages of a non-surgical approach are clear. No hospital admission costs, no surgical wound complications, and no anesthesia risks. The main historical disadvantage was a perceived slightly prolonged return to work or activity. However, even this is being challenged by modern functional rehab protocols. It is absolutely critical, though, that patient compliance with the comprehensive rehabilitation protocol is exceptionally high for this approach to succeed. Without strict adherence, outcomes can certainly suffer.
It's truly incredible how the evolution of rehabilitation has seemingly leveled the playing field in many aspects. Now, for those patients where operative management is still deemed the most appropriate pathway, what are the primary surgical techniques employed, and what are the specific benefits and risks associated with each, particularly with an eye towards optimizing outcomes?
For patients where operative management is deemed the most appropriate, typically those with acute ruptures within about 6 weeks, and often younger, more active individuals aiming for a quicker return, there are several key surgical techniques. The traditional and most established approach is open end-to-end Achilles tendon repair. This involves making an incision, typically longitudinal and just medial to the Achilles, crucial for avoiding the sural nerve. The perineum is incised, the torn tendon edges are exposed and meticulously sutured, together with strong, non-absorbable sutures. Common methods include Kessler, Bunnell, Krakow, or gift box techniques. The Krakow and gift box with interlocking stitches are generally considered strongest initially, allowing for early mobilization.
Stronger repair means earlier movement.
Potentially, yes. Post-operatively, the limb is typically immobilized in about 20 degrees of plantar flexion for 4 to 6 weeks. While historically this boasted a lower re-rupture rate, as we discussed, new evidence suggests no significant difference if modern functional rehab is used for both groups. However, using an early range of motion protocol after surgical repair is still associated with a decreased risk of re-rupture compared to prolonged immobilization. A variation is the mini-open repair. This uses smaller incisions to debride ends and place interlocking stitches, sometimes with small calcaneal incisions for bone anchors. It aims for a balance between security and less invasiveness.
And minimally invasive.
Then there's minimally invasive or percutaneous Achilles tendon repair. This is gaining popularity. Benefits include improved cosmesis, lower risk of superficial wound complication infection, potentially quicker return to work, and equivalent 1-year function compared to open repair. It's generally recommended within 2 weeks of injury. A crucial consideration, though, is the higher risk of sural nerve damage, up to 18% if the nerve isn't explicitly identified or protected. Despite this, it can be more cost-effective.
So nerve damage is the main trade-off there. What about chronic ruptures?
For chronic ruptures, typically older than 6 weeks where direct repair isn't possible without tension, reconstruction techniques become necessary. For defects under 3 centimeters, a VY advancement might be used, making a V-shaped incision proximally and advancing it distally in a Y shape. For larger defects, over 3 centimeters, a flexor hallucis longus, FHL transfer, is common. The FHL tendon from the big toe is detached and transferred to augment the Achilles, requires a functioning tibial nerve. What's remarkable is the FHL muscles adaptation, showing up to 52% hypertrophy after transfer, effectively taking on a new role. Other options involve using the plantaris tendon or parts of the gastrocsoleus aponeurosis for augmentation.
It's clear that surgical options are becoming increasingly refined and tailored. Beyond these traditional methods, regenerative medicine is evolving rapidly. What's the current evidence base, Professor, for using biologics like platelet-rich plasma, PRP, and bone marrow aspirate concentrate, BMAC, in Achilles repair? Is this where the future lies?
That's a pertinent question. Regenerative medicine holds promise, but the evidence, well, it's nuanced and sometimes contradictory. Regarding platelet-rich plasma, PRP injections, the literature presents a mixed picture. Some studies find no significant difference compared to standard care. However, other studies report more encouraging findings. better isokinetic muscle function, higher functional scores, improved ankle range of motion, and early return to activity, especially for sport-active individuals. So while a broad recommendation might not be warranted yet, there could be specific patient populations who derive a meaningful benefit. The mechanism is thought to be through concentrated growth factors stimulating healing.
And BMAC, bone marrow aspirate concentrate.
As for BMAC, the evidence appears more consistently positive. Studies investigating its use show improved clinical function and reduced foot and ankle pain without serious adverse effects. BMAC is rich in mesenchymal stem cells and growth factors, believed to enhance natural repair, stimulate fibroblast activity, and positively influence collagen synthesis and organization. While neither PRP nor BMP are yet standard care, their role in optimizing tissue biology and potentially accelerating functional return continues to be an active and exciting area of research. The challenge remains in standardizing protocols and identifying who benefits most.
So whether the initial management is surgical or non-surgical, it's abundantly clear that rehabilitation is the absolute cornerstone for optimal long-term outcomes. What are the overarching principles guiding effective rehabilitation protocols for Achilles tendon ruptures, regardless of how the injury was initially managed?
You've hit on the absolute linchpin of successful Achilles tendon rupture management. Rehabilitation is, without question, vital for regaining full strength, flexibility, and ultimately pre-injury function, irrespective of initial treatment. The overarching principle is a structured, progressive approach. This must critically balance respect for the delicate healing biology with the necessary progressive mechanical loading to stimulate optimal tissue remodeling, improve collagen alignment, and ensure robust strength gains. Balancing protection and loading. Exactly. The primary objectives are clear. First, restore optimal strength and flexibility in the Achilles and calf musculature. Second, improve overall lower limb function, ensuring harmonious interplay. Third, and perhaps most importantly for the patient, enable a safe, progressive, and timely return to their pre-injury activities. This is achieved through a carefully phased program. Controlled stretching, progressive strengthening moving from low resistance to higher loads, especially eccentric calf loading, and endurance activities like cycling or swimming incorporated early. A critical shift in modern rehabilitation is the increasing emphasis on functional rehabilitation, prioritizing early, controlled movement and progressive loading. This contrasts sharply with traditional prolonged mobilization.
Which wasn't always helpful.
While modern evidence strongly suggests this functional approach enhances recovery times and leads to superior long-term outcomes. Controlled loading stimulates advantageous collagen maturation, prevents muscle atrophy, and maintains proprioception and joint mobility. It's about finding that delicate balance. Protect the healing tissue while applying the necessary physiological stimulus for optimal regeneration.
That emphasis on functional rehabilitation and early movement is a true game changer. Could you walk us through the typical phases of rehabilitation, perhaps highlighting any specific protocols or critical considerations for each phase, both for surgical and non-surgical patients?
Absolutely. Rehabilitation is generally structured into distinct progressive phases. The early phase, typically 0 to around 2 or 4 weeks post-injury surgery, focuses on pain and swelling control. This is the initial immobilization period in a cast or boot, often in equinus. For non-surgical patients, usually initial non-weight bearing. Early physio often begins within days. Blood flow restriction, BFR training, might be incorporated here to maintain muscle mass and initiate early strength without overloading the tendon.
BFR, interesting. Then what?
As healing progresses, we transition into the mid-late phase. Emphasis shifts to controlled dynamic movements and sport-specific exercises. Key objectives: restore full ankle range of motion, rebuild local and global lower limb strength, and reestablish neuromuscular control and proprioception. This involves progressive resistance training, controlled closed kinetic chain activities like squats. For instance, guidelines suggest initial weight loading in plantar flexion, transitioning to neutral around 3.5 weeks. Barefoot weight bearing might start as early as 4 weeks post-op, depending on progress. Finally, the advanced phase, critical for returning to high-demand activities. Emphasis on high-intensity plyometrics. Box jumps, drop jumps, hopping drills preparing the tendon for explosive loads. Continuous objective assessment of strength and functional ability is absolutely necessary to ensure readiness and minimize re-injury risk. Low-impact exercises generally for the first 6 months, high-impact gradually after that.
Are there specific named protocols people thought of?
Regarding specific protocols for non-surgical functional rehab, the Glazebrook and Rubinger protocol is well known, often adapted. It outlines stages. 0 to 2 weeks non-weight bearing. 2 to 4 weeks gradual protected weight bearing in boot, 25% increments weekly. Active ROM to neutral, non-weight-bearing cardio. 4-6 weeks weight-bearing is tolerated in boot, maybe electrical muscle stimulation. 6 to 8 weeks gradually remove heel lifts, full weight bear in boot, 8-12 weeks wean off boat. For post-surgical rehab, exercises typically begin 2-4 weeks post-op, trend towards less rigid immobilization and earlier weight bearing. Post-immobilization involves progressive exercises, ankle ROM, resistive strengthening, isometrics, cardio balance. A crucial consideration throughout is avoiding aggressive hyperdorsiflexion early on, as this can lead to tendon elongation and long-term weakness.
So careful progression is key.
Absolutely. And trials like the STAR trial reinforce that traditional casting wasn't superior to early weight-bearing and a brace for non-op ruptures. This supports functional rehab consistently. Animal studies also show early loading improves collagen characteristics and decreases muscle atrophy.
That's a fantastically detailed walkthrough, Professor, making it very actionable for our listeners. No intervention, of course, is without potential risks, and long-term outcomes are a critical consideration. What are the potential complications of both surgical and non-surgical approaches, and what does the prognosis generally look like? What should we realistically tell our patients?
You're right, understanding pitfalls and setting realistic expectations is crucial. Let's first address re-rupture rates. Historically, non-op had higher rates, 10-40% versus 1-2% for surgery. However, as we've emphasized, the evidence has evolved dramatically. New Level 1 evidence from trials using modern functional rehab suggests no statistically significant difference in re-rupture rates between operative and non-operative approaches when functional rehab is used consistently.
Really levels the playing field.
It does. If re-rupture unfortunately occurs, treatment is typically surgical, often with augmentation. Turning to surgical complications, overall risk is about 5–10%. Key issues include wound healing problems influenced by smoking, female gender, steroid use, open technique. Sural nerve injury is significant, higher with percutaneous approach, up to 18%, if not protected. Other risks: infection, DVT due to immobilization, and aesthetic problems. It's a balance of benefits versus risks needing clear communication.
And non-surgical complications, besides re-rupture risk potentially being
For
mitigated.
non-surgical, beyond the historical re-rupture risk, patients may still face DVT risk and, importantly, potential tendon lengthening. This elongation, if it occurs, can lead to decreased plantar flexion strength, a persistent limp, and functional deficits. Patient compliance with rehab is paramount for non-surgical success.
So what's the general outlook? Prognosis.
In terms of overall prognosis, it's generally excellent with early diagnosis and appropriate management. Most patients return to previous functional levels, or close, within 4 to 6 months. However, full recovery, especially maximal strength and power, can take 12 to 24 months. It's a long game. For professional athletes, it can be more challenging. Over 30% may fail to return to their previous level after surgery. Those who do return often show initial performance dips at 1 year. Encouragingly, for those pros returning by the 2-year mark, studies show no significant difference in performance compared to baseline, suggesting continuous improvement after year 1. For some non-athletes, residual deficits like reduced range of motion or slight calf weakness may persist, especially if rehab adherence wasn't optimal.
That's a very clear breakdown of the recovery trajectory and potential challenges. Now, for clinicians advising patients, especially those at-risk populations like our weekend warriors, what are the most actionable and evidence-based strategies for preventing Achilles tendon ruptures in the first place? How can we empower our patients?
Prevention is absolutely critical, especially given the rising incidence. Several actionable strategies can significantly reduce risk. Firstly, fundamentally, gradual increase in activity levels. Tendons adapt slowly. Avoiding sudden load spikes, abrupt increases in intensity, duration, or frequency is paramount. A progressive loading program allows the tendon to build resilience.
I shouldn't do too much too soon.
Exactly. Secondly, the importance of proper supportive athletic footwear cannot be overstated. Shoes inappropriate for the activity or worn out can alter biomechanics and increase strain. Advise patients on selecting appropriate footwear. Thirdly, regular incorporation of strengthening and flexibility exercises is essential. Consistent calf stretches maintain optimal length. Eccentric strengthening, like slow heel lowers, is particularly effective for enhancing the tendon's load tolerance.
Eccentrics are key then.
They are a cornerstone, yes. For those with previous injuries, adherence to a structured prehab or preventative training program is paramount. This includes sport-specific balance and proprioceptive drills, core and hip strengthening, and ongoing cardio. It restores movement quality, not just strength. Finally, continuous monitoring and adjusting of activity loads is key. Patients need to listen to their bodies, recognize early signs of overuse, and adjust training. Adequate warm-up and stretching before activity should be non-negotiable. These empower patients in their own preventative care.
Professor Imam, this deep dive has been incredibly insightful, providing a truly comprehensive overview for our listeners. Considering the ongoing debate between surgical and non-surgical approaches, the diverse protocols, and those nuanced patient considerations, what does all of this tell us about the absolute importance of an integrated, interprofessional approach to managing these complex injuries?
The evolving evidence and inherent complexities undeniably highlight the critical need for an integrated, interprofessional approach. The fact there isn't a single consensus on optimal treatment underscores that no single clinician holds all the answers. Better patient outcomes are consistently achieved when a multidisciplinary team collaborates closely, communicating effectively with a shared understanding.
Who should be on that team?
Ideally, the trauma or orthopedic surgeon leading medical management. They must work hand in hand with rehabilitation specialists, like physiotherapists, guiding the intricate recovery phases. Sports physicians are vital, especially for athletes, advising on load management and return to play. Pharmacists are crucial for reviewing medications that might impede healing and advising on pain management. And critically, nurses contribute significantly through patient education on adherence, wound care, and monitoring for complications like DVT. Close, continuous collaboration between therapists and referring physicians is especially important for managing details like brace use and weight-bearing protocols. It's truly a holistic team effort for what can be a challenging recovery.
Professor Imam, this deep dive has provided such a rich, nuanced understanding for our audience. To leave our listeners with something profound to ponder as they continue their practice, what's one final thought or question you'd pose based on our discussion? Something that invites them to reflect further on the future of Achilles tendon ruptures.
My concluding thought would be this. We've seen the pendulum swing from rigid surgical dominance to an embrace of functional non-operative care. Perhaps the true gold standard isn't a singular intervention, but rather the art of precisely tailoring a dynamic, evidence-informed pathway to each patient's unique biological and lifestyle demands. Understanding that our role is not just to fix a rupture, but to restore a person's entire functional capacity. This raises the critical question. Are we truly ready to fully embrace and consistently apply this highly individualized, integrated functional rehabilitation as the absolute cornerstone, regardless of the initial intervention, and bed this philosophy seamlessly across all disciplines involved? The evidence certainly points us in that direction, but translating it into consistent, high-quality, individualized practice remains our collective challenge and opportunity.
Professor Moimam, thank you sincerely for sharing your incredible expertise and invaluable insights during this deep dive into Achilles tendon ruptures. Your guidance has been truly invaluable, and to you, our listener, we sincerely hope this deep dive has provided you with a clear, comprehensive, and engaging shortcut to becoming exceptionally well-informed on this critical orthopedic condition. If you found this deep dive valuable, please do consider rating and sharing it with your colleagues. Your feedback truly helps us continue to bring you these essential orthopedic discussions. Till next time, keep exploring, keep learning, and keep diving deep.